Hello, and thank you for joining us yet again for another episode of Matters of the Heart, a program brought to you by Haverhill Community Television as well as Pentucket Medical Cardiology. My name is Dr. Srivastava. I'm joined today once again by one of my associates, Dr. Seth Bilazarian, and to talk about a topic that is actually very timely because it's in the press and papers today as we're doing the show, but it's talking about the importance of quick treatment for heart attacks. And to expand on that a little bit more, when somebody is having a heart attack where an artery is blocked up, every second counts getting to the hospital quickly and getting treatment very quickly to get that artery opened up, so much so that we actually are measured and graded on how quickly we can get that artery opened up because we've seen better and better outcomes as that time has been reduced more and more. And so I'm going to have Dr. Bilazarian, the interventional cardiologist from our group, talk about this a little bit more. We often refer to it as a door to balloon time, and maybe he can explain a little bit more what that means. But with that, I will hand this off and hand this over to Dr. Bilazarian.
Yeah, I thank you very much for the introduction. So today I'm talking about a kind of heart attack, and the doctor's words for a heart attack are myocardial infarction, or MI is the abbreviated term. But we're not talking about all heart attacks. We're talking about a particular kind of heart attack, the worst kind, which is about 10% of all heart attacks. And these are called ST elevation MI. The short term is STEMI. And in the hospital, STEMIs are the worst kind of heart attacks because these are the heart attacks where the artery is completely blocked up. And we believe that every minute that that artery is blocked up, the heart muscle is dying. And we hear the term time is muscle. So every minute that's being lost, that heart artery is closed, that heart muscle is dying. And of course, the more heart muscle that dies, the more damage the heart will be, the less likely the patient will have a normal life, less likely they can return to work, less likely they will be able to live a life free of problems like congestive heart failure, a topic that you've covered recently for us. So there's a variety of really important reasons for both quality and quantity of life that we really want to go as fast as we can for these STEMI patients.
So before we even move on here, I just want to maybe quickly educate the viewing audience about what STEMI, what is STL? Is it, so maybe you can just explain a little bit what we're looking at on the EKG and non-STEMI. And
right. It is basically exactly what you just said. It's all about the EKG. Yeah. So this would actually be a good time. Maybe we'll just stop here. Yeah. So we're going to talk a lot about what you described about the race in the hospital, and it really is a race to try to do this as fast as possible. We have parameters, and we have goals, and we have report cards that say if you don't do it fast, you're not good as a hospital and as good as a group of physicians and nurses. So we are doing very well in our local hospitals here in the Merrimack Valley, I'm very proud to say, but it's a constant battle to keep doing better and better, and there's no end to it until it gets down to almost zero. So that's the race that we're talking about. But what I mentioned was this thing called a STEMI, S-T-E-M-I, and it stands for a particular kind of heart attack that in EKG shows that the part of the EKG is abnormal, it's elevated. So I'll just leave it at that to say that this ST segment of the EKG is elevated, and it's very characteristic. Some people say that the EKG actually looks like tombstones, which I think highlights how serious it is, that if you see these tombstones on the EKG, it's the worst kind of heart attack, and of course we don't want the patient to need a tombstone, so we want to really race to help the patient.
And then there's another thing that's often referred to as a non-ST elevation MI, or NSTEMI. And I guess for the sake of being simple, it's a heart attack, but doesn't have that characteristic.
Right.
And so we're going to be referring to the STEMIs,
right,
or the more urgent types,
right,
the kind that require immediate medical attention. And I guess we can approach this in a lot of different ways. Maybe, let's say, maybe we'll walk through a scenario. A patient develops crushing chest pain right here at home. Our advice, I think, the message we wanted to really send home is that call 911 immediately. Don't call your relatives in the West Coast to get their opinions. Don't lay down and think about it. Just call 911. And what happens from there? Maybe we can talk about that.
Sure. And just to amplify what you just said, so there's a very significant celebrity story that's been making the rounds, a woman named Rosie O'Donnell, who's a famous comedian and actress, and she had crushing pain in her chest, And she went on Google and spent the whole night looking up Google what the symptoms were. Could this be a heart attack? Was it something else? And she never sought attention until the next day. Fortunately, she had a critical artery blockage that wasn't complete, a 99% blockage, so she didn't sustain a heart attack, but she would have been much better off getting the attention that we're talking about. So one of the things that's critical in this time is muscle is to get help as quickly as possible. And as you said, if you call relatives, if you have someone bring you to the hospital, it actually is worse than calling 911. If you call 911 and say, I have chest pain, I need help, ambulance will come and take care of the rest. That's really the most important message we want to give. If you want to change the channel right now, this is a good time because you got the message. If you have chest pain, call 911. And we're going to tell you some reasons why that's important if you want to understand it. But if you don't understand it and you do it, that's the most important thing.
Sure.
So a lot of people have said over the years, well, I feel like I live close to the hospital. I can just jump in the car with my spouse and get there faster. But that's not good because you could go to the wrong hospital. The wrong hospital that doesn't have the kind of facilities that can immediately open up the artery will delay your treatment. So you'll have more heart muscle damage. There's a famous story of the Red Sox player Tony Conigliaro, whose brother threw him in the car and tried to get him to the hospital as quick as possible and got stuck in traffic, and he suffered severe consequences for it. So there's plenty of examples out there of celebrities who are smart people, who have resources and wealth, who have done the wrong thing, and we hope our patients will call 911 if they have chest pain. I do want to just put this in perspective. This is a big problem. 500,000 Americans have this kind of heart attack called STEMI, 500,000 Americans annually. In our own local hospitals, of the hospitals in the Merrimack Valley, the hospitals that have this facility are Lawrence General Hospital and Holy Family Hospital. We still don't want you to go there. We want the ambulance to take you there, but those facilities have them. And each of those hospitals do over 100 of these patients per year, to put that in perspective. Each hospital. Okay. So this is happening 2 times a week at each hospital or 4 times a week in the Merrimack Valley to some patient who's brought to the local hospital. So it's not that infrequent a problem, unfortunately. So just to put that in perspective for our citizens, or our viewers.
So to go through the example or scenario, a patient develops this crushing chest pain, does the right thing, calls 911, ambulance gets there. Maybe you can walk us through what's happening from a system standpoint, right, from there, and how do we succeed, or what systems are in place to get us to succeed, to get the patient into the treatment center as quickly as possible.
Right. So the biggest innovation that you've just laid up for me to hit out of the ballpark is that the ambulances now are equipped with EKGs. Because earlier we said that the only way to make this diagnosis is with an EKG. So you used to have to go to the hospital, get the EKG done by the emergency room staff, and then make a determination. Now the ambulances have the EKGs on board. So they can see the patient has this ST elevation or STEMI type of heart attack, and the patient will be immediately transferred to the center that has the facilities for this, rather than going to one hospital and then being transferred to a different hospital. So that's a huge innovation, number one. But the second reason why, and then why we're telling patients to call 911, is when you're in your own living room, they're calling the staff to get ready for you. So while you're being brought to the hospital, we're getting the facilities ready. We're turning on the x-ray equipment. We're opening the packages of balloons and wires and catheters. So when you arrive, we're already halfway started to getting the patient on the table ready to go. So that is the most important thing. There are other parts of this. We're skipping over them. Of course, there's important medicines that have to be given to patients, but those are given in the ambulance, like aspirin. Additional medicines like Plavix or newer forms of Plavix are given in the hospital emergency room. But again, just harping on this 911, if you didn't do that, and your spouse took you to the local hospital, you wouldn't get these treatments, and we wouldn't even know you had it until you arrived at the hospital. It takes 5 or 10 minutes after you arrive in the hospital to get the EKG.
Even longer sometimes, too,
right,
if it's crowded and hectic and crazy.
Right.
And
right, exactly. And as you said, even further, we've had numerous stories of a patient going to the nurse receptionist at the emergency room, and will say something that misleads them and says, I'm having a little pain, I think I have some gas. And the nurses will sit down and we'll get to you. And then 2 hours later, an EKG is done and the patient was having a heart attack because they said, I was having some gas, instead of saying I have chest pain. So that's an example of how 911 if you have chest pain.
Yeah, and I'm thinking back now to when I was doing my cardiology training down in a Boston hospital. at a time where these facilities weren't available in the community hospitals. I can remember being on call, getting phone calls about a patient in a hospital an hour away saying this person's got an ST elevation MI, heart attack, we need to send them to you to get treatment. And I can remember numerous times getting to the hospital, just sitting there waiting and waiting and waiting, sometimes hour and a half, even longer. And it's critical, that whole time, just the muscle tissue's dying and the heart's dying. And it was really a shame. I mean, it was...
Yeah, I'm sure you do follow some of those patients who had that care, because before 4 years ago, we didn't have those facilities locally, and our only option was to send them to Boston. And of course, we're blessed in this state to have fantastic Boston hospitals. But to go to Boston, it's only 45 minutes away, but it's just not worth it. You want to go to your local close hospital.
Yeah, and 45 minutes sounds ideal, but it's not. By the time you're first treated at the first hospital,
right,
and then phone calls are made and things are made,
right,
and it adds up the time.
And there's this other thing called traffic.
Yes.
That can make longer than 45 minutes. And I have a patient that suffered that consequence from traffic. So it's wonderful that we have these facilities locally. And now, so let's talk about it. So one of the exciting things that's just been reported is that Medicare looked at 300,000 patients with this ST elevation MI in 900 hospitals in the United States, and showed that from 2005 to 2010, the average went from 96 minutes, so an hour and a half, to 64 minutes. So in those 5 years, we've cut 30 minutes off it.
And so what are we defining? What is this time from?
So thank you very much. So that's what's called door to balloon time. So we are now marked for quality for hospitals, marked from when the patient hits the door at the hospital.
So it doesn't count someone who's sitting at home for hours with their pain. Okay.
But that is important. So you're right. And that, again, is the message. We can only control what we can control. So if a patient sits at home for 3 or 6 or 12 hours, if they sit at 12 hours, the heart muscle is already dead, and we can't help them. So this is only for patients who come in the first 6 hours. But the sooner they come, the less heart muscle they're damaged. But you make the good point that we're only talking about what we can control, but we would love, through public service announcements like what we're doing right here, is to shorten that pain to door time. So the pain to door time is completely on the patient. Yeah. And many of our patients say, no, I don't want to go, or I don't want to call an ambulance. Everybody in the neighborhood will know. I hear this stuff from my patients. Right. I don't want to do that. I don't really think it's a problem. What happens if I go and it's not really a heart attack? Well, so what? If it's not really a heart attack, they'll send you home. But if it is a heart attack, your life could be saved and you'll have a better quality of life. So that shortening that door to balloon time by calling 911 is critical. But what we're talking about today is what's really happening is really every effort to shorten this door to balloon time. And the balloon is the angioplasty balloon.
Right, so not just starting the procedure, but we're
actually opening the artery.
Okay, and so in 2005,
right,
it was an hour and a half
right,
on average. So you come into the hospital, we know your diagnosis, and it took an hour and a half to ultimately get the artery open. Okay. Yes. And so now what is it?
It's 64 minutes on average. So now the national standard is everyone should be less than 90 minutes. Yeah. But we're seeing more and more in our local hospitals have really put these systems in place, and we're seeing it that it's getting all the way down to almost routinely less than 65 minutes. That's now the routine. And it's really a wonderful thing because it's nice to see cooperation. Like, I am an interventional cardiologist. I do this procedure. I open up arteries in the middle of the night with heart attacks. But it doesn't matter if I'm good or not if the team doesn't work together. And we're seeing now that every day a scorecard that comes out anytime one of these patients come in. How do we do it every step of the way? And we have guidelines that a patient should have an EKG within 5 minutes of coming into the hospital. Then within 5 minutes after the EKG, a doctor should look at it and decide it is one of these heart attacks and call out the team to come in. So that's already 10 minutes now. Yeah. And then within 30 minutes, the whole team has to be in to get the patient to the catheterization laboratory where we do the procedure. So now that's 40 minutes, and that leaves us 20 minutes to get the artery open to get it under 60 minutes. So we're really trying to push the envelope to really push this. And it's one of those things that we know that it's the right thing to do. The data is overwhelming that this is the right thing to do. It's the safest way to treat these patients. They'll live longer. They'll live better because they don't have heart injury. But it's almost opposite in what a lot of things are happening in other areas of medicine where we want people to take their time. make a decision, get second opinions if necessary,
Yeah, not for this.
make sure all your questions are answered. And it's you can see the anxiety because I'll sometimes see family members, a son or a daughter, and I'm saying we really want to go quickly, and this is the right thing to do, and I know that it seems like you're being rushed, but we're doing it on purpose for the patient's benefit. It's one of the areas that's opposite of, in most areas of medicine, we're going an opposite way. Take your time, make sure you understand, ask your doctor questions.
Right.
Here we're saying,
nope,
let's just go as fast as we can.
Yeah. Now, all right, so it's a phenomenal improvement over this short period of time. What do you think has led to that improvement? What specific changes in how we practice? And I think we already alluded to some of them with regards to the ambulance, but maybe you can highlight some of the different things.
Yeah, so there's a lot of, again, they're not the guys that do the procedure like me that have really changed. It's these systems. Yeah. So one thing, and you probably remember this when you were in your training, that there was a time where we didn't trust the emergency room doctors to make this call. Yeah. So what would happen is the EKG would be done, the emergency doctor would look at it, then the emergency doctor would fax it to the cardiologist and say, well, what do you think? Well, that adds time. So that adds 5 or 10 or maybe even 15 minutes by the time the fax comes through, the call comes back. So we've taken that out of the system. We don't rely on the cardiologist. We say, you're good enough emergency room doctors, call this. Will come in when you say, and even more so, we're saying it, the ambulance drivers can call this. The whole team comes in, even if the ambulance drivers call this as a STEMI.
And I guess it's better to err on the side of caution. So if it's not, or a misread of the EKG, no harm has been done other than waking some people up.
It is waking people up. It is an issue more complex than just waking people up because it's a resource thing. And of course, hospitals are now strapped. And if you're going to call in 2 nurses and a radiology technician, you're going to have to pay their time. So there is a resource utilization. So around the country, sometimes this has gone as high as 40% of inappropriate calls. Wow. In our local hospitals, I just saw the data yesterday, for the whole year, we had 20% of inappropriate calls. So we'd like to see that to be a little bit better, but you're right. We'd rather err on the side of too many than too few. We don't want to miss any of these, but maybe 10% would be a better number. So we're working towards that.
So I'd be curious about some of the data on the local hospitals. So because I don't even know some of this data or statistics. So you said 20% inappropriate calls.
Right.
And what's the door-to-balloon time for the local hospitals?
The local hospitals, we're seeing almost all the time less than 90 minutes. The ones that we're seeing that are less than 65 minutes are the ones that are the out-of-hospital notifications. So if the patient comes to the hospital and presents with chest pain, those are more likely to be between the 65 and 90 minutes. Yeah. But the ones where the ambulance is bringing the patient and getting notified, those are almost always less than 65 minutes because we are, as I said, assembling the team and ready to go. And
so I guess just for the sake of being repetitive and driving home the point, that's the main point, is that call 911. Don't get in the car and drive yourself or have someone else drive you because you will clearly do better the quicker you are in the cath lab.
Right, and also that other point is there are many good hospitals, but there's only a couple hospitals in the area that do this procedure. So if you go to the wrong hospital, meaning a hospital that doesn't do this procedure, that's going to further delay because now we have to wait for an ambulance to come and get you, which often takes a long time, to bring you to the other hospital, and that's going to be a real significant problem.
Yeah, no, I've seen. Now, you've probably done more reading on this than I have. So nationwide, what are some other strategies that have been put in place at hospitals that have helped?
So the one was to get the cardiologist out of the initial notification. That was a big thing. And then a simple strategy where the technology exists where you can send a page out to everyone immediately. So there was a time where you had to call the doctor page, call the nurse page, call the technician page, call the other nurse page, and then wait for them to all come back. And now we have a system where the nurse in the emergency room presses one button and the page goes out to everyone.
Well, it's funny you mentioned, so I can remember very vividly during my cardiology training as the cardiology fellow, I was often the first call from the outside. So some doctor from some other hospital call and tell me this is what I got. So I said, okay, send them. And then I would have to figure out how am I going to do this. So I'd have to page the interventional cardiologist on call. We actually had an interventional cardiology fellow on call, so I'd have to call him. I'd have to call the nurse. I'd have to call the technician. I'd have to call the hospital to book a bed. And so I was trying to do this while driving to get there, which isn't very smart to do either. But it's a lot of phone calls to make, and you got to wait for. It's the middle of the night often, so waiting for them to call back. It was a suboptimal system. So clearly that bit of technology has made things better. What else?
Right. So these are great points that you're making up. So that centralized paging system, and that only came about because there's been pressure that this is a quality marker. So the hospitals, of course, will immediately invest in something if there's going to be something really scrutinized and looked at. And this door to balloon time, sometimes abbreviated, if you want to read about it on the web, as D, the number 2B, D2B, door to balloon time. So it's the central operator. We mentioned having the emergency room doctor or the ambulance physician or ambulance staff be able to notify this. And then having certain expectations, like I said, having an EKG within 5 minutes, having notification within 5 minutes, and myself and all the staff are expected to be within the hospital within 30 minutes. So people have to be ready. You can't answer your page and be 40 minutes away from the hospital.
Go take a shower or something.
You can't go take a shower. You have to, I have my scrubs and my shoes next to my bed. So I'm on the way within minutes of the pager going off. So these kinds of expectations. And then I would say it's a sort of constant systemic feedback. Like we're constantly at the local hospitals thinking what strategies can even take an extra minute off. So I'll just give you a dumb example. Sounds dumb, but we're just trying to think of everything. When a patient comes in on the ambulance stretcher, we now are saying, let's not even transfer the patient to another stretcher in the emergency room. Let's leave them on the ambulance stretcher, give them the medicines that they need, and then take them on the ambulance stretcher right to the catheterization laboratory.
So I was going to ask you, so I'm not there in the middle of the night dealing with, are these patients bypassing the ER? They're not stopping for an or is it a very quick cursory evaluation there and then going upstairs? How's that working?
Well, again, for the ones that are notified by the ambulance, they often within minutes can come up because the staff is ready.
Yeah.
But of course, if they come to the hospital, we have to wait.
Because these out of hospital ambulance,
yes.
They've called in, you guys are mobilized, ready to go. Are they stopping in the ER for traditional get blood tests, this, that, the other thing, or no? They're just going past
No. I mean, they may get some very quick things. There is these medicines I mentioned, like the Plavix, that aren't given in the ambulance, so we want to get those on board. But yes, that's done very quickly or very briefly. So just use an example, like should we take the extra time to move them back and forth on a stretcher? Or do we just leave them on all the portable monitoring equipment that the ambulance guys have, and then just take the patient right to the emergency room? So sort of the catheterization laboratory. So these are sort of systemic things that we're constantly looking at, and we are being evaluated, and we should be, and we're very excited. But I think that the message on this that we spent most of the time talking about is this door to balloon time, which is the hospital responsibility. The patient has no involvement, but the area where the patient does have the involvement is the before the door, and that's the pain to door time, which we really want them to help us with as much as possible by calling 911.
It's a big issue. And same with stroke. A lot of these discussions we're having are very similar to the stroke literature and stroke research. And same thing, just people need to get in there quickly. So with these improved door to balloon times of 30 minutes, what have we seen with regards to outcomes in that setting, or as far as how patients do?
Well, we know that from traditional standpoints that the earlier patients get treated on a door to balloon time standpoint, that mortality does come down significantly. Mm-hmm. So mortality comes down as much as 10% every 10 minutes, or 1% per minute. So if we can move from 90 to 60, that's a really significant improvement in death rate for these patients. It's really remarkable because these have traditionally been the worst heart attacks, and these patients are now getting treated so promptly that the heart muscle is recovered so quickly that we're sending these patients home with just 2 nights in the hospital. Yeah. It really is amazing that these were the patients that were in the hospital for 7 days and had congestive heart failure, had really poor outcomes, and it's really a remarkable history. I mean, the history of this is just a remarkable achievement for our specialty. I mean, I'm proud to be a member of this specialty. It's not me, it's a proud member of the specialty that we went, just as a reminder from a historical standpoint, to use drugs that did this. These drugs were clot-busting drugs. They have problems because they have a higher stroke rate, to now moving to the standard of care of using these balloons because they have a lower stroke rate, but excellent outcomes in terms of opening up the artery.
Yeah, and so, there's a few minutes left before we have to come to a conclusion here, and I'm trying to think what the best thing to talk about now. I mean, would it be useful to discuss a little bit about the actual procedure itself when someone's in the throes of a heart attack and in the cath lab?
Sure.
What we're talking about balloons and what is all this about, and maybe you can walk us through that a little bit.
So the patient comes from home, they're on a stretcher, they're met by myself or another interventional cardiologist in the emergency room. We ask them to give us their permission, but it's very rushed. We rush them to the catheterization laboratory. Now, the trend in our local hospitals, I'm very proud to say, is we're doing these procedures almost exclusively from the wrist artery. That's been shown to have much lower rates of bleeding because we use very high doses of blood thinners because we're dealing with clots. So the bleeding rate is very high. Sometimes we still have to use the groin for technical reasons, but we do it from the wrist. We can open up the artery within 30 to 40 minutes of being in the room. The patient has almost immediate relief of pain. So this artery was blocked. We put the balloon in, we open it up, and the pain goes away. It's a really remarkable and really gratifying thing for patients. And then we finish the procedure usually by putting a stent in that artery. We take the equipment out, we put a wristband on, and the patient will go to the intensive care unit for overnight stay. So it's a really remarkable achievement. I'm not saying it always is something that's successful. There are, of course, some patients that are so sick or they present late that they actually die in the catheterization laboratory. It's still a very serious problem, but we're seeing more and more patients do the right thing and come early. And with these medications, we're seeing really dramatic improvements and going home, as I said, 2 nights later.
Yeah, I got to say, just anecdotally, I feel that more and more folks that I have who've gone through this come out looking great, more and more than what I can remember even just 6, 7 years ago when I first started up in this area.
And I think it's all about this coming and getting done quicker.
Yeah, no, absolutely, because then these local hospitals couldn't do the procedure, so everyone from the local hospitals would get put in an ambulance and sent down to Boston or Burlington or somewhere else, and time is muscle, as we say. And so it is remarkable in the hospital on day 2 or day, just seeing how good people look for the most part.
Right.
There's exceptions every now and then, but
right.
People come out looking really good for the most part.
One of the downsides of that, and of course we want our patients to do good, but this is such a serious consequence that I sometimes worry that patients don't take it seriously. They had a little heart attack and they got fixed up and now they're fine. And of course, that's a different topic for a different show for us. But this is a very serious problem, and we do have really great prevention strategies which really require close follow-up with their primary care doctor and their cardiologist to get all the numbers in good range.
Yeah, no, I think this has been great. This has been a very useful, as we're wrapping it up here, a very useful review of, I think, something that's really neat and that we're able to offer in the local hospitals in the Merrimack Valley, specifically at Holy Family Hospital and Lawrence General Hospital, the ability to very quickly and effectively and with quality, the ability to take care of these life-threatening medical problems very quickly. We do a great job here, and so I think it's nice to inform the public. I think the take-home message, if you're going to take home one message from this whole thing, is chest pain, call 911. Don't mess around with it. Don't sleep on it. Don't think it's indigestion and just pop some Tums. Don't call your relatives. Just call 911. Don't get in the car yourself or have your wife or husband drive you. It's just call 911 because it can really make a big difference between having a life of really significant chronic medical problems or death or moving on and carrying on with a normal life, and it's a really important thing. And so I think that's probably the number one take-home message from today. And so with that, I'd like to thank Dr. Bilazarian for a great review. We'll wrap this up, and this was another episode of Matters of the Heart. It was brought to you by Haverhill Community Television, as well as Pentucket Medical Cardiology, and thank you for joining us.